Hello, everyone, and welcome. My name is Martha Macaluso, and today I'm going to be teaching you about what orofacial myofunctional therapy is. I hope you enjoy the course. Course objectives. Upon completion of this course, students will be able to have a basic understanding of what orofacial myofunctional therapy is and how it works, learn about the importance of the therapy, have a basic understanding of what orofacial myofunctional disorders are along with their etiology, and be familiar with various assessments used for orofacial myofunctional disorders. What is orofacial myofunctional therapy and how does it work? Myofunctional therapy is the neurologic re-education of the orofacial muscles. It is a rehabilitation therapy program that is designed to repattern the somatic gnathic functions such as chewing, swallowing, and breathing. Now, this is accomplished through the use of therapeutic techniques and positive behavioral modification. The therapy allows the brain to develop new neural pathways through repetition, time, and experience. Once the new behavior is learned and adopted, those neural connections are reinforced. This creates a more permanent neural change, commonly known as neuroplasticity. Now, the repetition of the therapeutic techniques will help to increase the strength, tone, and coordination of the stomatognathtic muscles and help to develop facial symmetry. What's the purpose of the exercises? Well, the exercises have a few different purposes. They help to recover and improve dyskinetic muscle function. They help to restore deficient muscle tone, reacquire correct postures such as tongue, jaw, and lips, re-educate functions such as swallowing, chewing, and breathing, and reduce and eliminate habits such as thumb sucking, pacifier use, nail biting, lip or hair sucking or biting, tongue sucking, leaning, and others. Now, awareness and elimination of oral habits must be addressed conjointly with myofunctional disorders, or they may affect the fluidity and process of the therapy. Here in the United States, breathing reeducation is incorporated along with chewing and proper swallowing in order to assist in the treatment of the myofunctional disorders. Breathing education looks at nasal breathing versus mouth breathing and the volume of air taken in during inhalation and the muscles that are recruited during breathing, so the movement of the diaphragm. Now, both oral habit elimination and breathing education are important for continued positive progression and desired outcome of the therapy. Additionally, to achieve optimum results, myofunctional therapists work collaboratively with ear, nose, and throat doctors, allergists, and orthodontists, to name a few. The importance of myofunctional therapy. Myofunctional therapy for the treatment of myofunctional disorders has demonstrated to be an important adjunct in the treatment of sleep disordered breathing, orthodontic treatment, temporomandibular joint dysfunction, masticatory dysfunctions, and digestive and postural problems, to name a few. Now, myofunctional therapy also addresses any underlying issues pertaining to various health related disorders, and therefore it aids in the reduction of general healthcare costs. So, myofunctional therapy can aid in the restoration of continuous nasal breathing, and if it is implemented during the early years of development, it can positively affect the craniofacial growth deficits that are associated with sleep disordered breathing. Breathing reeducation as adjunctive therapy in the treatment of sleep disordered breathing. Now, currently, clinical studies have proposed that breathing reeducation is a necessary adjunctive therapy in the treatment of sleep disordered breathing. And part of the therapeutic breathing techniques include correct use of the breathing muscles, reducing or normalizing the correct volume of air, and timing the therapy at rest during activity, speech, sleep, and sport. Myofunctional therapy to improve airway patency. Adenotonsillectomy is often prescribed in children to improve airway patency and symptoms that are associated with sleep apnea. However, a child who has suffered from having enlarged tonsils and enlarged adenoids may have ingrained habits such as mouth breathing, poor oral resting posture, where the tongue sits low and forward on the floor of the mouth, and even improper breathing patterns. Now, these perpetuating habits, if not corrected, can promote relapse of obstruction and affect proper oral facial growth. For that same reason, myofunctional therapy should be incorporated into the protocols following the adenotonsillectomy. Now, myofunctional therapy should also be performed after the surgical procedure in order to create proper oral resting posture and help promote proper nasal breathing. Now, the rehabilitation process of the orofacial and oropharyngeal muscle groups create adequate airway patency. And as you can see, a meta analysis was conducted by Camacho et al., and it demonstrated a decrease in the frequency of apneas that were measured by the apnea hypopnea index, or also known as AHI. Now, it demonstrated that the children's AHI decreased by 62% and for adults by 50% after going through myofunctional therapy. What are orofacial myofunctional disorders? Orofacial myofunctional disorders are also known as OMDs, and they are a group of various stomatognathing functional disorders, and they can affect directly or indirectly dental occlusion, stability of outcome of orthodontic treatment, stability of periodontal therapy, temporomandibular joint dysfunctions, facial aesthetics, facial skeletal growth, pharyngeal airway dimension, and speech, to name a few. Etiology of orofacial myofunctional disorders. The etiological origin of OMDs is multifactorial, and it is difficult to isolate a single factor. Now, some causative factors include, but are not limited to, noxious oral habits, such as thumb sucking, nail biting, etc., bottle feeding, baby food leading to incorrect chewing and or swallowing, pacifier and spouted sippy cup overuse, structural airway restriction, restricted or altered oral tissues such as tongue or lip ties, enlarged tonsils and or adenoids, craniofacial development, so underdevelopment of the maxilla and the mandible, and facial asymmetry, to name a few. Assessment of myofunctional disorders. Now, professionals who work with myofunctional disorders have different tools that are available for assessment based upon their needs, their scope of practice, and preferences. Myofunctional therapists, being a multidisciplinary group, uses various tools and practices which often overlap but retain some individual characteristics depending on the background of the therapist. Now, moreover, myofunctional therapies are better trained to identify some concurrent signs and symptoms of sleep breathing disorders, which then allow the proper referral along with education of patient and caregivers and treatment of the underlying oral facial functions, which are either affected or are a contributing factor in sleep disorders. Some of those assessments may include whether or not the patient breathes through their nose or their mouth, and what the palate width is. The palatal width is essential as a narrow palate will indicate that the tongue is not fitting properly in the oral cavity and it may obstruct the airway. And here you can see on the image a mouth breathing individual's palate compared to a nasal breathing individual's palate. You can see that the nasal breathing individual has a much wider palate than the mouth breathing individual, because when you are breathing through your mouth, the tongue is not making that proper oral resting posture, which means the tongue is not being in contact with that maxillary arch in order to help shape the palate. Pharyngeal airway dimensions are higher in nasal breathers than in mouth breathers. This three-dimensional assessment of the pharyngeal airway in nasal and mouth breathing children demonstrated that mouth breathers have significantly smaller airway space compared to the nasal breathing individuals. Continuing with the assessment of myofunctional disorders, next on our list is the tongue assessment. Is the tongue sitting low and forward at rest, which means it's not making proper contact with the roof of the mouth? What is the tongue size? Is the tongue enlarged? Is the tongue scalloped? Now, usually when you see a scalloped tongue, that's an indication that the tongue is not fitting adequately in the oral cavity, and the teeth are literally biting the sides of the tongue. Now, any of these contributing factors may also signal an airway impingement. Swallowing and chewing is also assessed to make sure that there is not an abnormal swallowing pattern contributing to the disorder. And a tongue thrust evaluation is also done, which in most cases goes hand in hand with having a swallowing dysfunction. Noxious oral habits, such as nail biting, thumb sucking, lip licking, smoking, pacifier or baby bottle use, and cheek biting, to name a few, are also assessed as they can contribute to such disorders. Posture is also assessed, as having a forward head posture can indicate an airway impingement, as you can see on the picture. Postural characteristics of patients that are affected by oral breathing. Assessment of the orofacial muscles is also performed in order to make sure that everything is working uniformly. Having an overdeveloped mentalis muscle and or facial grimace may be an indication that there is an excessive circumoral movement, hence contributing to an excessive activity of the mentalis muscle, which will then contribute to an overdeveloped mentalis muscle. Lack of a lip seal. This can be due to either an airway obstruction, a restricted maxillary labial frenum, and or a restricted lingual frenum, in which case would contribute to habitual mouth breathing. Restricted frenums, such as a labial, buccal, and or lingual frenum, in which case can contribute to craniofacial changes, airway impingement, digestive problems, and other overall health effects. The use of the Mallampati score, which is seen on the screen, or the Friedman score, are used in order to help assess the airway. And in many cases, a Class 3 or Class 4 Mallampati score may indicate an airway obstruction by the tongue. Now, it is very important to note that only a sleep study done by a sleep medicine doctor can diagnose if there is an airway problem such as obstructive sleep apnea. Therefore, patients must be referred accordingly. Assessment protocols used. Some of the assessment protocols that are used during an orofacial myofunctional evaluation include, but are not limited to, orofacial myofunctional evaluation protocol with scores known as OMES, the orofacial myofunctional evaluation with scores known as MBGR, the assessment tool for lingual frenulum function, ATLFF, designed by Hazelbaker in 1993, Ankyloglossia, tongue tie, a diagnostic and treatment quandary by Kotlow in 1999, Lingual Frenulum Protocol with Scores for Infants by Marcusson and Martinelli in 2012, and the Lingual Frenulum Protocol by Marcusson in 2014. Who does myofunctional therapy? Well, many healthcare professions from various countries adopt myofunctional principles within the scope of their practice. But in the United States, specifically, speech pathologists, dental hygienists, physical therapists, and occupational therapists are the primary providers of the therapy. In all cases, an additional postgraduate training is required. The myofunctional therapist. Through the use of various fun, easy to use tools such as buttons, strings, and chewing devices, myofunctional therapists help patients have better control of their orofacial muscle functions and tongue placement, establish a proper oral resting posture, establish a proper symmetrical chewing and swallowing pattern, which involves gathering the food in the middle of the tongue and swallowing without the assistance of the perioral muscles, enhance proper breathing patterns, enhance functional posture, and eliminate oral habits that interfere with the process. Now, the therapy is progressive, whereby the exercises are sequential and become more advanced as you move along. Certain exercises are repeated during the therapy depending on the needs of the patient while focusing on the goals of the therapy. Now, the therapy program is usually done over a period of a year in order to attain long term retention of the results. The team approach. Myofunctional therapists generally work with a team. They include dentists, orthodontists, medical doctors, speech therapists, lactation consultants, physical therapists, cranial sacral therapists, and sleep medicine doctors, and more, depending on the needs of the patient. Now, prevention of myofunctional disorders may be possible now through early intervention with therapeutic techniques that have been used in pediatric dentistry, speech therapy, and orthodontics for many years. More research is needed in this area, but preliminary studies are supporting the value of changing the function as well as the structure in order to successfully treat and prevent many disorders. The team approach is the most important and the most beneficial avenue for the patient's health and well being. Treatment of myofunctional disorders. Treatments of myofunctional disorders include isolating and activating muscles in the head and neck and repatterning them to optimize proper function. Now, some signs and symptoms of OMDs include, but are not limited to, mouth breathing, tongue thrust, tongue or lip tie, parafunctional habits, chewing disorders, facial muscle dysfunction, enlarged tonsils or adenoids, TMD, sleep disordered breathing such as obstructive sleep apnea, malocclusions, high vaulted palate, tongue scalloping, hypotonic masseters, speech misarticulations, low tongue resting posture, infant feeding problems, and more. Early intervention is key. Educating the expectant mother about the detrimental effects of pacifiers and or baby bottle use, benefits of breastfeeding to promote a wider palate, the importance of frenum screenings in order to avoid cascading overall health effects down the road, the disadvantages of feeding infants soft foods. In cases where infants eat smooth foods, the infant learns not to masticate. So, consequently, proper chewing may never develop, causing the muscles associated with the airway to collapse. Also, not digesting their food properly occurs with a lack of chewing, and it may lead to aerophagia. Now, let's take a look at a couple of more research studies. The effects of orofacial myofunctional therapy on temporomandibular disorders. This study concluded that OMT had the following positive effects in treated patients: a significant reduction of pain sensitivity to palpation of all muscles studied but not for the TMJs, increased measures of mandibular range of motion, a reduced Helkimos D and AI scores, reduced frequency and severity of signs and symptoms, and increased scores for orofacial myofunctional conditions. This study conducted on patients treated with orthodontic myofunctional therapeutic protocol concluded that orthodontic treatment alone in the presence of bad habits is not enough to solve the orthodontic issues, so it needs to be combined with myofunctional treatment. Make sure to check out our chapter on the treatment of myofunctional pathology in the sleep disorders in pediatric dentistry textbook. And for more information about myofunctional disorders, please make sure to visit dentalbrushup.com.